So Jason read off my title. The basic idea of this study was I was fortunate enough to be in an acute setting over my CP2 placement, and I was on the limb salvage floor for a few weeks, and I came across this patient. So he was a diabetic foot ulcer patient, as I'll explain later on in the slides with a patient background. But with a limb salvage, you end up having a lot of plastic surgery involvement, and we wanted to kind of look more into the early mobilization protocols after a split thickness skin graft for one of these non-healing diabetic foot ulcers. It's a huge issue that's going on, and I have the numbers to back that up here in the next slide. But it was a very interesting patient. He had a very complex past medical history, and he was really interesting to kind of work with and get to know over 2 weeks' time. We kind of went through the different mobility, functional things for him, bed mobility, transfers, and eventually into ambulation once we got through all the basics. And he had a history of multiple failed procedures and a history of noncompliance with PT interventions and the different post-operative precautions. And I think the real meat of the study is to get into what can we do as a PT profession in this field. You go through the literature. Right now there is a ton of literature on split thickness skin graft, free flap procedures. However, there's very little on the PT side of it in terms of our interventions in the acute field. And beyond that, a lot of the interventions are very short-term based, and we don't really talk too much functionally as to what PTs are doing in that setting. So a little background on diabetic foot ulcers and the patient himself. So diabetes type 2 especially, huge issue. Almost 400 million people globally with diabetes. And CDC estimates that it could double by 2030. So we're talking, 600-700 million people globally with this epidemic, and it's a huge cost on our healthcare system, $11 billion annually when you think about everything included with diabetic foot ulcer impairments. So about 25% of patients with type 2 diabetes at some point in their life will develop a foot ulcer, and 58% of those patients are going to have an infected ulcer, which is going to lead them to the probability of having surgery, debridements. You're going to have, and then a higher risk of amputation. So you see there, amputation risk at 1 year after a foot ulcer has been diagnosed, 13 to 40%. Obviously, that's a big range, but the literature kind of varies on that one based upon a lot of things, past comorbidities and such. And then you look at the 5-year risk. Up to 80% risk of amputation following a foot ulcer. So it's a big comorbidity in the diabetic population and a huge cost on our U.S. healthcare system. We talk about the pathophysiology of a foot ulcer. So typically they're a combination of ischemic and a neuropathic impairment. So generally you're going to see some atherosclerosis of the arteries, and then you're also going to see degeneration of the neurons and the axons locally. Generally, it appears distally, typically in the feet and hands, and then you typically see the ulcers appearing more on the feet. As time progresses and you see you generally will see the autonomic function go away first, so the regulation of the hot and cold, sweating of the feet, and then you have sensory impairments then come after that, which is then where you start to really start getting that risk of developing an ulcer, and then your motor impairments, which also further contributes to that. You start losing some of the muscular control of the ankle, you start having pressure distribution imbalances within the foot, which leads them to a high propensity for developing a foot ulcer down the road. Generally, some of the literature indicates that initially when patients start to develop ulcers and start to develop neuropathy of the feet, their arterial supply is still okay, but their arterial supply diminishes very rapidly as compared to a normal person. When you see peripheral arterial disease in these patients, it's something that occurs much more rapidly as compared to typical population. And as with the case in this patient, the posterior tibial artery was the biggest one in question, which supplies the vast majority of the vasculature of the foot. So it's a kind of a good diagram that goes into explaining how does diabetes contribute to what we see at the end of, a lot of the end road for a lot of these patients, which is an infected gangrenous foot. You kind of see how the polyneuropathy begins, the autonomic sensitivity and the motor functions begin to kind of sequela down, and you start to develop all the different issues, puts them at a higher propensity for the biomechanical dysfunction, higher risk of pressure distribution within the foot. And then, of course, you run the big risk of them not feeling an injury to their foot, which is generally what happens. And is the same with this case. Patients may stub their foot on something, have a cut, they don't realize it, and then over the course of a couple weeks it becomes infected, and before they even begin to realize it or they do a self-check, they already have an infected wound, and then they find themselves in the emergency room. So current treatments, conservatively, it's a lot of the stuff that we've learned in the classroom, things like offloading, total contact casting. Education's a big one, and in and out education is going to be huge for any patient with diabetes. You talk about orthotics for the patients that begin to have a motor dysfunction to try and help better support that foot as the Charcot foot kind of starts to come in. And then, of course, you have your wound care, topical debridements and gross debridements, and then wound vacs. And then, the peripheral revascularization, angioplasties, and stenting is kind of on that borderline between getting to the conservative to an aggressive approach. I mean, as a surgical approach, of course, it's a low-risk surgical approach, but it helps with trying to maintain that blood supply and vascular supply to the extremity. And then as you get further down the road, with those fail, you start looking to surgical sharp debridements, skin grafting procedures, which of course we're going to get into here, and then ultimately you hope to avoid an amputation for these patients. So split thickness skin graft, free flap procedure. I'm going to refer to it as a flap to make it simple. Generally, you're going to see it it's kind of like the last ditch effort before the amputation in a lot of these patients. I was fortunate enough to sit in on a surgery. It's about a 6-7 hour procedure for the procedure. It's done primarily by a plastic surgery team. Sometimes it's a multidisciplinary team between plastic and vascular surgery. But the split thickness graft, which is what we're talking about here, they take primarily the epidermis and only a portion of the dermis, whereas a full thickness, which is used for more like of the more aggressive burns, you're going to see the epidermis and the dermal layer both taken out. And then the flap, which is kind of like the encompassing thing that makes us unique, is that they take a portion of the muscle belly from a donor site within the patient. So this particular patient had his vastus lateralis on his involved extremity. A portion of that resected. They maintain the vascular supply of that, and then they put that into the wound site. The lats are another big donor site. I mean, you can sometimes see the rectus abdominis used, but it's generally any sort of flat muscular group that they can kind of take out and then place in that area. And then kind of the end portion of that procedure, after they take the skin graft, they take the muscle graft, is they have to reattach the vascular supply, which is very amazing to watch. I would describe it as tying two wet noodles together, but not even tying them together, basically pressing them together. So there's an end-to-end anastomoses, and then you have the end-to-side anastomoses based upon whether you're doing the artery or the vein for the donor site. So kind of putting it into picture here makes it a little bit easier to understand. You can see the difference in the split thickness versus the full thickness, how much of the graft they're actually taking, and then they take a dermatome and they just run right down. So they took right down his thigh, take a nice big chunk out, and they run it through a mesher, and they kind of save that until the end of the procedure, and then they end up suturing him up with that over the flap placement. So this kind of puts it into perspective as to what it would actually look like. So this patient, obviously with a large wound, this was actually a burn patient, but it was, I think, the best depiction of what the patient looked like and what these wounds typically look like. So the patient that presented, you did see exposed bone and tendon, which you see here. You see how, if you look here, there's not a whole lot, tendons exposed here. You have a lot of exposed all the way down to the subQ layer, and then they put the flap over it. I believe this was also a vastus lateralis donor, and then you see the drain from the drains coming out there, and they also generally put in a venous Doppler as well, so that you can monitor that, which I'll get into as we go into PT intervention. But then you see the end result at 12 weeks, and it's not the most pretty foot in the world, but it's functional, and it's healed. And that's kind of the end goal. So the patient that I treated was a 59-year-old African-American male, long-term history of diabetes. He had a complex medical history, like I said, schizophrenia. He was intermittent bouts of homelessness over the past 2 years, which kind of came into play because he was uninsured, cardiomyopathy, anemia, hypertension. Fortunately for him, no history of smoking, which is a big factor in terms of wound healing. But you go through, when he presented, he came into the emergency room with complaints of foot pain. He noticed that he had the wound, and at this point it was a 5 by 2 centimeter deep wound. I mean, he had exposed bone already before he even came into the emergency room. So he kind of obviously let that go a little too long. So he went through, I believe he was admitted to the hospital for 2 or 3 weeks before I had seen him, before he got his flap. He had 2 failed sharp debridements. They had a posterior tibial angioplasty done to try and improve the vascular supply to the extremity, and offloading failed. No real wound healing was seen. A couple weeks later, plastic surgery was consulted. His wound was by 6 by 3 now. His femoral pulse was pretty much diminished. So they consulted for the flap procedure and underwent the successful flap procedure, fortunately for him. Went well. We saw him 2 days after surgery, so he was on bed rest for 2 days post-op. We evaluated him, and as you'll see here, I kind of talk about the dangle protocol. So fortunately, at the setting I was at, they practiced the early mobilization dangle protocol. Some physicians, and as you read through literature, have a very conservative protocol in which they want bed rest for 5 days. Some of them I've seen 7 days, bed rest with elevation, no movement of the surgical extremity. Our physician at the setting I was at, they were much more progressive, and once they're medically stable, they had him out. So once bed rest orders were taken back, PT was placed, we eval'd him. He was pretty limited in all of his bed mobility transfers, and we did not attempt an ambulation at the time. So he was under the dangle protocol, which you'll see here on the next slide. And its idea of it is throughout the course of the day, he has his leg elevated, and then over time, you're going to slowly progress the amount of gravity-assisted blood flow to the lower extremity. So he's going to sit up at the edge of bed. So our first treatment was essentially just sitting him edge of bed, seeing how he tolerated it, sit with his foot dangling. He was non-weight bearing, which ends up being the biggest limiting factor because of his comprehension, whether it was his past medical history of the schizophrenia or not, that kind of interfered with it. He didn't really comply with the whole non-weight bearing thing very well. So the first time he was okay, we just had to keep kind of reminding him what to do, and then the main intervention was just education. As you see, as we went through here, the next 3 to 4 days, we slowly got more and more. We got him sitting edge of bed, then we attempted transfer training. First time we attempted to sit to stand transfer, he tried to put his foot down. Obviously that's shunned upon. So we kind of kept going back and forth with him, trying to keep educating him. Finally, you'll see there on day 6 post-op, there was a little friendly wager between the OT and my CI and myself. She said that I guarantee you I can get him to stand without putting weight down. And he said there's no way, he's not going to do it. He hasn't done it for 2 weeks. Well, she won the bet, and he ended up pulling it off. We had 3 of us there. We got him to stand. We gave him tactile cueing to his surgical extremity, the left side, kind of kept him up there. Strength-wise on his non-surgical leg, he was strong. I mean, he could perform transfers pretty well, and it ended up just being a big education piece, constantly reminding him, constantly leaving reminders around his room to try and help facilitate that idea of you can't put weight down on your left foot. You can't put weight down when you get out of bed, those kind of things. And by the end, day 12, he was able to, we had 2 treatment sessions with him for about 45 minutes. He was able to walk around with a rolling walker twice for about 10 feet. Really didn't need any assistance, didn't need much verbal cueing, just the occasional reminder to make sure that he adhered to it. And then at the end of every treatment session, we also had to check with the Doppler that was in place to make sure that there was still good perfusion in the area. So as you see on the table and here on the results page, initially poor compliance, poor comprehension of what was going on and what we were trying to accomplish, but with continued education, continued intervention, and that max verbal cueing and 3 therapists working with him, essentially, he kind of started to catch on to what we were trying to do and really kind of, was successful. He had no issues. The big thing that we determined as a success was there's a little window in the post-op dressing, so you're supposed to do a visual inspection of it to make sure there's no excess drainage over the surgical site. And every time he was good, the venous Doppler checked out good, and he never really had any issues. And then he ended up being discharged to a acute rehab hospital to NRH, and we were lucky to also have a great case manager who was able to get him DC Medicaid to get him into NRH. The big downside, I think, to the study is that there were no formal outcome measures, and I kind of hinted to that at the first slide as to what the true value of the study is, and it's highlighting that yes, we had a successful outcome, but what is defining our successful outcome, and how does our early mobilization protocol compare with other more conservative protocols? Is there a difference? And I think the plastic surgeon that I was able to get to know a little bit there, she was very forward-thinking and wants to do more research using outcome measures and PT to see how successful the flap procedure can be with this protocol. So main conclusions from the study is getting a patient post-flap out of bed once he's medically stable is safe. It's a good thing to do, and I think it's going to help them improve their outcomes in the short term, and it's not going to hinder their outcomes in the long term. Generally, you see about an 85% success rate of a flap procedure in a diabetic population, and that's at a 12-week follow-up. You see some literature that says up to 95% at 2 weeks, and then some literature that says 70% at 6 months. So there seems to be like kind of a variable window there on what is defined as a successful outcome. But the big thing is it's safe for this patient, and he didn't have any adverse outcomes. The graft site remained intact, and everything went well. I think that he was able to achieve, relatively independent mobility in terms of his transfers. He still needs help with, his ambulation. Obviously, he's still non-weight bearing for the next, I believe he was non-weight bearing for 6 weeks. So he had another month to go before he could put weight down through that foot. But the beauty of it is he was able to kind of work on those transfers, get to acute rehab setting, and continue to work on his long-term mobility goals. So the biggest limitation of the study, like I hinted to again, was the no outcome measures. And I think that is where the direction of the future study should go for us as a PT profession and with the multidisciplinary team in the acute setting. If you think about looking at what outcome measures could we use, whether it might be the lefts or the 6-click short form, which I think would be great. You can look at a very functional mobility type thing, whether it might be FIM, which I know they would probably put into use once he got to the acute setting. Those are the little things that I can really help prove validity to what we're doing as a PT profession and help show what the benefits are of getting patients out of bed within that first 2 days versus waiting a whole week to get them out of bed on bed rest. These are my references if you'd like to learn more. Any questions? Dr. Donovan.
So what was the patient's pain level like when he tried to put his foot on the floor?
He really didn't complain about pain. He was in a multi-POTUS boot. He was in a lot of pain meds. Okay. And he was really interesting. I remember my CI kind of like, I saw him after his first debridement. He's kind of a weird guy. Like he had like a calculus book that he was reading. We walked in one time, he was reading a world history textbook. So there was always like the question of cognition. Is it really there? I mean, conversationally, he was totally intact, with alert and oriented at everything. I mean, conversationally, he was fine, but he never complained of pain, never said anything, he was an easy guy to work with, which was nice. Yes? Yeah, I mean, I think that's certainly, he was on a lot of pain medication. I think he was on Dilaudid and like Percocet. He was on all kinds of stuff. I would have to think that his long-term history of diabetes and neuropathy would have to contribute to that. And I mean, the shame of it is, he gets discharged at 2 weeks and he disappears, and I don't know what happens to him. You hope for the best, and you think that he's going to have a good outcome, but who knows? Correct. Right. So when they put the flap in, they don't reattach the nervous supply, because the idea of it is they don't want it to be innervated so that the musculature dies and just turns into essentially tissue. But I think within the rest of his foot, you would have to think that the nervous supply is diminished big time.
You don't want to ask about mobilizing?
If we were going to do some PAs.